Good morning, Dr. Mack.
Hi, how are you?
I'm good, thanks. So I think we will get going today. So today, Dr. Jabour had another commitment that she couldn't miss. So I'm introducing Grand Rounds for today. And today is the last Grand Rounds of this academic year. We'll be taking a summer break and resuming again in September, just for people so they don't tune in next week. So we'll start as always with our land acknowledgement. Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived on this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis peoples and their valuable past, present, and future contributions to this land. Today, we're very fortunate to have Dr. David Mack presenting Grand Rounds. Dr. Mack is currently a professor of pediatrics at the University of Ottawa and a senior scientist at the CHEO Research Institute. His pediatric gastroenterology fellowship training was completed at the Hospital for Sick Children in Toronto. And then following training, Dr. Mack was appointed to the Faculty of Medicine at the University of Nebraska Medical Center. In 2001, he returned to Ottawa with a mandate and a vision to develop a pediatric gastroenterology, hepatology, and nutrition program. He aligning excellence, staying focused on the goals, consistency, optimism, patience, integrity, respectfulness, passion, and communication defined his tenure in leading the division and developing IBD research endeavors. Dr. Mack is currently the director of the CHEO IBD Center, studying the importance and role of the intestinal microbiome in IBD. He recently received the Canadian Association of Gastroenterology Distinguished Service Award and the University of Ottawa Faculty of Medicine Distinguished Chair, Clinical Research Chairs. Congratulations for those. So today, Dr. Mack is going to present on thromboprophylaxis in pediatric inflammatory bowel disease, because you don't know, but he secretly wants to be a hematologist. Welcome, Dr. Mack.
Thanks, Donna. And you're right. It's kind of nice to cross over and talk about work we've been doing with our colleagues and some of the work that's been coming out lately that culminated in some international consensus. And so today's topic is the thromboprophylaxis in IBD, and the objectives are really to recognize that children with IBD are at risk.
David, do you want to just switch? You're on presenter mode, not show mode.
Is that better?
That's perfect. Thanks.
Sure. So discuss the safety of using enoxaparin in hospitalized children with UC, and evaluate the need for thromboprophylaxis in hospitalized children. So in terms of thromboembolism events, there's cerebrosinus, venous thrombosis, deep vein thrombosis, pulmonary embolism, all of which we've seen here at CHEO. And these events are associated with a high mortality rate, persistent recurrent thrombosis, post-thrombotic symptoms, and persistent neurologic deficits. And there's a number of reasons that in IBD, the children are at risk of thromboembolism, and these include procoagulant effects, platelet activation effects, and impaired fibrinolysis effects. So in adults, there's been more work of this for a longer period of time, and so for about 10 to 20 years, there's been this knowledge of VT events in active IBD, and this was done by population-based epidemiology, hospital-based epidemiology studies in adults, and even increased mortality of hospitalized ulcerative colitis patients. And this led to guidelines being developed over the years, and it first started with the Canadian Association of Gastroenterology guidelines in 2014, and they recommended that prophylaxis is for all patients with IBD that are hospitalized adult patients. And then the Europeans in 2016 extended this and said it should be considered following discharge, after surgery, or in outpatients with active disease. The American College of Gastroenterology in 2018 and 2019 split between Crohn's disease, in which they had no recommendations, or ulcerative colitis, which they also said basically use low molecular weight heparin in all hospitalizations with acute severe colitis. And the British Society of Gastroenterology agreed with that, which then led to this international consensus in adults with IBD just last year. And there's a number of statements that came out, but the pertinent ones for today's talk is thromboprophylaxis should be given to patients during IBD that are hospitalized and maintained during inpatient, but extending it to outpatient is really those for just strong risk factors of developing thromboembolism. It could be considered in ambulatory patients with IBD if there's risk factors for VT and maintained until remission. And in reviewing all the literature, thromboprophylaxis was not found to increase the risk of any IB or GI bleeding in patients with active disease. So what about children? Well, the same Canadian group that had, started off the recommendations to say it should be used in all adults that are hospitalized, came out opposite for children and said no prophylaxis in children with IBD-related hospitalizations. The Europeans nuanced it a bit and said, well, no, you should probably use it in adolescents with acute severe colitis if there's one or more risk factors, or prepubertal 2 or more. And ambulatory care in Crohn's disease, there is no recommendations. But these Canadian guidelines came out with that because at the time they were being done, there was very little literature in pediatrics, and what was there was from a Danish civil registry study that's population-based. And much like Born here in Ontario, the data was from birth. And they were able to find about 50,000 IBD patients and matched it against about 500,000 general population patients. 203 they identified with a thromboembolic event versus about 2,000 that did not. And these are based, matched with age, gender, where they live. And what they found was the chances of a thromboembolism event in IBD was about twice that of the general population of children. That under 20 years of age, these events were relatively low, but the relative risk of VT and IBD versus controls was 4 times higher than in elderly. But, they said, we don't really know what the safety is. And so at that point, they said, that thromboprophylaxis may not outweigh the risks, which led to the Canadian guidelines in 2014. Since that time, there's been other registries set up. This is be coming out shortly, this paper, and it's European registry with about 20 countries. And so they had about 25,000 IBD kids. They had 20 cases documented when they started this. Most were in ulcerative colitis, and cerebral venous thrombosis was the most frequent. Most were all active disease. Nobody was on prophylaxis. And rather than 4 times risk, they documented a 14 times risk. And this led to an epidemiology study that was centered out of CHEO here that was administrative data-based with across Canada. And they were able to identify about 3,500 kids with IBD versus about 15,000 that were age matched. And rather than 16 times the risk, they documented 40 times the risk of developing a VT event in children with IBD. Most were in the first year when they're most active. And it was about double in ulcerative colitis versus Crohn's disease. So rather than saying it wasn't a very important event, we concluded that this was a pretty important event in children. And certainly here at CHEO, we've experienced a lot of issues with this prior years. The North American Society of Gastroenterology sent out a survey to its members in 2018, and almost all the respondents were aware of this increased risk of thromboembolism and IBD. And actually most had experienced an event themselves in a patient. But interestingly, only about a third of the MDs really provided VT prophylaxis for their patients. And when asked why, they said, well, there's just not really much of a literature supporting it. So I guess that shows the importance of guidelines now. but there was still this concern and 50% saying, well, you know, if you use this, it's a risk of rectal bleeding and it may make it worse. And that's despite, you know, about 15 years of adult studies saying it wasn't. But there was no literature out there at all. So around 2011, there was some winds of change that were happening, and enoxaparin became widely available at CHEO in 2011. And this thromboprophylaxis emerged as a clinical topic. And one of our hematology colleagues was particularly interested in this. And around the same time, the care for IBD was changing a lot as well. And so one of the studies that we're involved with really looked at early infliximab, sort of around day 3 to 5, rather than waiting a lot longer. And there was much better outcomes when we were looking at length of hospitalization and surgery. And so over the years with these changes, the amount of surgery that's done in UC has decreased about 400%. And so this severe ulcerative colitis protocol has been in place for about 10 years now. Then another one of our hematology colleagues, you know, was interested in kind of looking at the experience here. So we worked together to develop this study, and it was a retrospective then from 207 to 216 on enoxaparin use in children admitted to CHEO, and we focused on the ulcerative colitis. And these kids could either be admitted through the emergency room or the clinics. And we collected the hemoglobin values as one of the primary outcomes for the first week following admission or until blood transfusion. The UC treatments were guided by this severe ulcerative colitis protocol, but ultimately was by MD discretion, but the enoxaparin use was all protocolized. And our study questions were, does enoxaparin administration increase the risk of blood losses? Does it increase the need for blood transfusion? And is its use safe in children admitted with ulcerative colitis? So the study population over this was 500 IBD kids, about 250 then had ulcerative colitis. 25 or about 10% of them had a blood transfusion right on admission, so those were removed. And then there was some without enough data to really make it useful. So we had a cohort of 218 that we looked at. And then these were separated out by those that received enoxaparin and those didn't. And there was no difference in sex, median age, baseline hemoglobin, or corticosteroid use, but they were different populations. And these were the differences that you can see. So those that were admitted after 211, more likely to be on enoxaparin. Infliximab use was more likely. Severe disease, this is sort of interesting because this has been the progression of changes in hospitalization, and far more were severe when they came in the enoxaparin group. Colectomy was higher and central venous use was higher. So the ones on enoxaparin were much sicker. So this is our data on change in hemoglobin for those with severe UC that came in over the first 7 days, and there was essentially no difference. When we looked at all patients admitted since 2018, same thing, there was no difference between cohort or those receiving enoxaparin. Then the other part of when we looked at blood transfusions with those that received enoxaparin or not, again, there was no difference in those requiring a blood transfusion or not. And in terms of looking at VT prophylaxis safety outcomes, the Mitchell group really created 3 criteria for evaluating VT prophylaxis safety measures. And criteria 1 is a major bleed, which is a fatal bleed, a drop of hemoglobin of greater than 20 grams per liter, a bleed that was retroperineal, pulmonary, or intracranial, and there was no incidences of those. Their second criteria, which what they called clinically non-relevant major bleeding, or the need for the blood transfusion, as you saw, there was no difference. Their third criteria of minor bleeding or overt or microscopic bleeding obviously is not measurable in this cohort of patients. So our study conclusions then in this paper that just came out last year was the use of VT prophylaxis, which was low molecular weight heparin, is safe in hospitalized ulcerative colitis patients. It's not associated with increased blood losses, major bleeding events, or clinically relevant blood losses. And prophylaxis doesn't lead to an increased need for blood transfusions. So with these literature that were coming out on VT events and prophylaxis, really out of Ottawa, that got into the literature, there was a group over in Europe that were putting together what's called a RAND panel. And so we were invited to participate in this. And this is a kind of another methodology that came out of RAND and UCLA. That's a validated method, uses a Delphi model that combines expert opinion with the best available evidence. And the aim, rather than developing PICO questions like the methodology out of McMaster, they provide clarity and appropriateness of interventions for specific clinical scenarios. And so this was a 12-person panel with pediatric gastroenterologist, hematologist, adult and pediatric surgeon, and a nurse with IBD experience on this. Literature search was performed, disseminated to all the panelists, including all the preprints that were coming out. And then the panelists were asked to rate appropriateness providing this thromboprophylaxis for specific clinical scenarios. And so we'll go through those. But one of the things that we first worked on was the thrombotic risks in pediatric IBD. And that includes severe disease, surgery, smoking, oral contraceptive, complete immobilization, central peripherally inserted central venous catheters. And I might add, at CHEO, we had a heck of a time of this at one point, and so we just don't use them anymore. Obesity, concurrent significant infection, family history of thrombotic disorder, systemic steroids, and parenteral nutrition. So this is really then getting into the RAND panel discussions that we had, and I'll sort of walk through these different figures because they're a bit complicated, but get to the various points. So in this first column here, they had the different type of patients. So this would be the prepubertal, and this gets to those previous European where they separated this nuance kind of thing. And then they had the older patient, the 15-year-old, and separated it initially to male and female. And so then the question was, in this new onset acute severe colitis that gets admitted to hospital, what was the opinion in offering no prophylaxis? And there was a strong consensus that this was not appropriate to not offer it. And then on the flip side, they said, well, what about giving the thromboprophylaxis in these different type of patient or ages of patients in an acute onset severe colitis? And everyone felt that it was appropriate. So there was strong consensus on that. And then the third thing was, well, what about until clinical remission? So, with our severe ulcerative colitis prophylaxis, we usually send them home when they're down to a milder range, but it's not completely no inflammation. And so this said, well, we're not sure, if you need to do this. So this is still an open question. So another clinical scenario then is shown on this figure. So this is a prepubertal, and this is the older patient in either sex. And this is for admission for a patient who's known ulcerative colitis and has extensive disease. So extensive disease to us in the IBD world is that disease that starts in the rectum and is extended past the splenic flexure. So if it's distal to the splenic flexure, like descending colon and rectum, that's called a limited disease. And if it's proximal to that, it's extensive, remembering that ulcerative colitis is a continuous inflammation from the rectum anywhere to the cecum. So for this extensive known patient who has a flare, then it was also then broken into these risk factors, either none or one. And again, this goes back to some of the earlier guidelines. So even with no risk factors and it's extensive disease flare, there was strong opinion that it's inappropriate to offer no prophylaxis, and they should be offered prophylaxis until they go home. But again, until clinical remission, it wasn't so sure, because most of them, when they start to go home, are much better. And then they this was sort of a priori, so they had this broken out to no risk factors and one risk factor. And essentially with no risk factors, it's exactly the same as one risk factor. So if they're extensive disease, you don't have to go through the list. Do they have a risk factor? It's basically, if they're sick, start them up on the prophylaxis, was the opinion. So this is getting into the third clinical scenario then. And the age groups are the same, younger and older. The risk factor is no risk factor, more than one risk factor. And this is for the limited ulcerative colitis. So, this was sort of an interesting thing, because, if you think of a proctitis, they're not that particularly sick. And, do you go in with prophylaxis, and what's the risk of bleeding? But then really everyone said the chances of a simple proctitis getting admitted to hospital is so remote that we'll just leave it at this limited proctal ulcerative colitis. So up to the level of the splenic flexure. The other thing was argued, if these kids are sick enough, you're not going to do a full colonoscopy anyway. And if you put it in and you're in the sigmoid and it looks really bad, you may not really go past it anyway, but these patients can become quite sick. So it was left at this without nuancing it down to the proctitis versus left-sided. So with that being said, that for these no risk factors, for the very youngest, there was some uncertainty. And so there was debate on this, and I think offering no prophylaxis, we'd call it uncertain. But the older child, it's inappropriate not to do it. So interesting, on the flip side, offering prophylaxis in the youngest, they said, that's appropriate. But going home, when they go home until clinical remission, again, is uncertain. If it's more than one risk factor, and one risk factor might be on steroids, and there's almost nobody that comes into hospital that isn't put on steroids, and offering no prophylaxis is inappropriate. It should be done, and when they go home, doesn't necessarily need to be on it. So the other thing is colonic Crohn's disease, and clinically these can be very similar to bad ulcerative colitis. Younger and older patients, no risk factors, one risk factor. Offering no prophylaxis, uncertain, but offering it is appropriate. So it's sort of an interesting dichotomy that shows up, but it is what it is. And then going home until clinical remission, again, it's uncertain. But if it's more than one risk factor, so, we had that list, and certainly all these are mostly going to be on corticosteroids anyway. Offering no prophylaxis, inappropriate. They should be offered it, but once they go home, not necessarily being on it, but not necessarily a bad thing to do. So now we get into the ileal Crohn's disease, and this is the vast majority of patients, 60% in pediatrics with Crohn's disease, have the terminal ileum and ascending colon involved. So this is the most common, whereas the younger the Crohn's patient is, the more likely they're going to have colonic disease. So this is another common group, although the amount of Crohn's disease that gets admitted to hospital is incredibly small. Mostly this is an outpatient disease now. So the vast majority that come into hospital are colitis symptomatology. So in terms of these ilio-Crohn's disease, with the two age groups, no risk factor versus one risk factor, there was a lot of uncertainty in this age group with no risk factors, but more than one risk factor for a child that's hospitalized. These are the ones that, may have the abscesses and, be quite sick. Inappropriate not to offer it, appropriate to offer it, uncertain about when they go home. So this led to then the panel consensus, in which, go with the low molecular heparin until hospital discharge for all pre-pudescent ulcerative colitis, all new onset severe colitis, and all Crohn's disease patients with more than one risk factor. And then really all younger patients with more than one risk factor, or, for us here at CHEO, it's going to be those ones on corticosteroids. So this topic is far from over. I mean, there's a lot of areas to sort of think about that need to be looked at. And the oral thromboprophylaxis agents, there's just not much literature in the pediatric IBD field. What to do about outpatient and then post-surgery. We didn't attempt to tackle that one at all. So those are still open. So, in terms of acknowledgements, there's a lot of people that went into this for sure. And Jackie Halden, who was the head of HEMONC for a number of years, was really the pioneer in this whole thing, in putting the enoxaparin protocol together and working on it. And she actually would do every single consult at one point on these kids coming in. And then it's just sort of been handed a lot over to GI since that point. Eric Benchmall, when he was here, worked on the epidemiology, and that's his studies considered probably the strongest in this field of epidemiology in pediatric. Eden Story is the one who initiated this study, and Chelsea Penny was the medical student who did a lot of the legwork on this. I'd also like to thank my division colleagues for moving forward with this. And this is, this whole study is basically through the clinical research unit at CHEO. So we had the database, that was housed by them. We had Chelsea got a summer student grant to put this together. And then all the stats analysis was done by the group, because this is one of those unfunded studies along the way that just came together with the benefits of the CHEO Research Institute. And so with that, happy to try and answer any questions people may have.
Awesome. Thank you, Dave, for that super interesting talk. I don't see questions yet in the chat, so people are welcome to either put a question in the chat, raise your hand, or just unmute yourself. I guess I'll just ask a question. So we work alongside with you frequently, and I have to say the enoxaparin now we're not consulted because GI is taking the lead, and it's really great. The one time that we do get consulted is when these kids are needing a transfusion. They're on enoxaparin prophylaxis, and then they're needing a transfusion, and everyone gets very nervous about them being on the enoxaparin. And I just wonder if you can comment on that, or what your opinion is on that.
Well, it's sort of interesting in the pathogenesis of IBD, and these really severe ones, when they lose their bowels and you look at it, there's a heck of a lot of thrombosis in the small vessels in these bowels. And so at one point, there was some studies that actually looked at straight heparin in these patients to see if it would prevent IBD going to colectomy. And whereas that didn't help at all, those patients did bleed more. So that then led to this enoxaparin use. And for years and years now, the adults have said, no risk, no risk, no risk. So this was sort of the first pediatric crack at this thing. Now, if I'm, you know, sitting in the shoes of a kid who's severely hemorrhaging, not getting under control with the IBD, I'm going to be a little nervous to continue the enoxaparin anyway. But if the transfusion is because the kid's really down low, you know, it's been a chronic process, you know, the MCV's low and this has been going on months and months, I'm not thinking it's a severe acute bleed and the risk of problems from the IBD are going to be worse. So I don't know that I'd necessarily have a blanket answer for that. I think it's sort of based on the individual patient and where they are in their course of disease.
Perfect. Thank you. I'm just going to, Dr. Matt Speckert, who is on his second last day of fellowship in HEMONC, has a question. And then we have one in the chat from Jason. So Matt.
Hi, I was just curious if you came across anything in the adult literature for using oral anticoagulants for this purpose.
So there are a number of oral things out there now. There's been no studies that I'm aware of that have looked at it in the outpatient. And so the consensus is really if they have more than one risk factor for developing a VT event, they should probably do it. Now, whether, you know, I think, you know, the adults are using less and less of the enoxaparin just from cost and all the other factors and more, but that's wide open now for looking at. So I don't have an answer to your question. I saw Jason asked about the experience on the expert panel. You know, to me, the process of this RAND and this RAND process, from my understanding, came out of the Marshall Plan in the World War II to rebuild, you know, Germany, and it was kind of, you know, there isn't a lot of evidence, but what should we do and get together and do it? And they've now extended it. UCLA took it over and put it over into the medical field, and so it's a validated process. A lot of the processes are similar to what happens in other kind of consensus guidelines. They do a literature review, it's sent out to everybody, you review it. I think the big difference between this RAND process and the other processes is in the other processes, you think up questions a priori and then try and answer them with the literature review. In this process, you know, it was, okay, well, this is VT and IBD. And so the pediatric literature was sent out and they even got preprints and sent it out to everyone kind of read it through. And then they, rather than questions about, you know, is it safe to use it, you know, in IBD, they put these clinical scenarios forward. And so it's a far more clinically oriented approach. The people on it sort of say, okay, well, here's a problem I have. You know, what about this? So that's where these clinical scenarios came up. There's a few other ones like, you know, should we stop the enoxaparin before they go for endoscopy and biopsy? You know, and so there's not a literature on that particular question, but you sort of read the literature and make your best guess. So I think the RAND process is prior to there being randomized controlled trials to review. It's just here's the literature, whereas the McMaster process is, you know, what kind of studies are out there with the double-blind placebo-controlled being the strongest, and then case series and then individual reports. So it's more clinically oriented, it's more undefined, it's really early type of thing. When they come out with these informations, you know, they don't say this is a consensus guideline or you know, clinical practice guideline. They say this is where the current not enough literature is at. So they're quite different processes, and each, have a strength and a weakness.
Great, thank you. Dr. Halton has a question for you.
Yes, I am so not knowing how to raise my hand on this Zoom. So I just have a question. This was absolutely a wonderful overview of IBD and the efficacy of using low molecular weight heparin or an anticoagulant. When we look at the use of anticoagulants, we look at both the efficacy, but also the safety. And you had mentioned the article by Mitchell, but I think it needs to be emphasized to this crowd that that was just not a paper by a group. That was from the International Society of Thrombosis and Hemostasis. It was from the Scientific and Standardization Committee, so that anybody who was using anticoagulation, we had parameters to identify what was the criteria: major, clinically relevant, non-major bleeding, and minor bleeding. So I think, like, you've done an excellent job in showing the efficacy, but I think you also need to point out that this was probably one of the first times that we got hematology and GI together to be able to say, this is what we should be using to look at the safety of anticoagulation in all areas of pediatrics.
Yeah, thanks, Jackie. And, as I was mentioned, you were the pioneer in getting this stuff going here at CHEO and working with us. And, I mean, all those points are terrific to know. But I might add that this safety paper that just came out is really the first in the world literature in pediatric IBD. So there's been a lot coming out of Ottawa. This was a big group effort. To me, it's all good.
Great. Are there any other questions out there? Okay. Well, thank you very much, Dr. Mack, for that really enlightening and highlighting what's come out of CHEO and in terms of research and bring the forefront of what we should be doing with these IBD patients in terms of anticoagulation. So thank you very much. Thanks everyone for attending. And again, just a reminder that this is the last grand rounds of this academic year, and we'll start again in September. Have a great day.